Hello, my name is Courtney, and my presentation is over the effects of an IV magnesium sulfate shortage on critically ill patients. My colleagues and I who worked on this project have nothing to disclose. Hypomagnesemia, though this threshold may vary, is commonly defined as a magnesium level less than 2 milligrams per deciliter and is a common problem that affects 10 to 30% of hospitalized patients, with a higher frequency occurring in critically ill patients. Complications of this electrolyte deficit can include arrhythmias, seizures, weakness, ataxia, as well as other electrolyte abnormalities such as hypokalemia. For patients with hypomagnesemia, magnesium can be replaced either orally with magnesium oxide or intravenously with magnesium sulfate, depending on the severity of the serum magnesium deficit. In terms of elemental magnesium, 400 milligrams of oral magnesium oxide has 240 milligrams of elemental magnesium. However, only about 30% of that is actually absorbed, so that's more like 72 milligrams of elemental magnesium. And then comparatively, 1 gram of IV magnesium sulfate has 98.6 milligrams of elemental magnesium, and this has a much higher bioavailability. And additionally, oral magnesium oxide has the risk for increased adverse effects such as diarrhea and the potential for increased C. diff testing by healthcare personnel, and its reduced bioavailability raises the concern for inadequate magnesium replacement and prolonged hypomagnesemia. This study was conducted at Greenville Memorial Medical Campus, the main campus of Prisma Health Upstate, a large acute care hospital in Greenville, South Carolina, with 117 ICU beds. Within our institution, an adult ICU electrolyte replacement order set is utilized for magnesium replacement in adult patients within the ICU who have a serum magnesium level less than 2 milligrams per deciliter. This order set is activated by nursing personnel based on the patient's magnesium deficit, and the nurse is to order a recheck serum magnesium level drawn with the following morning's labs, unless a patient's magnesium level is 1.3 or lower, in which case the nurse would order an additional recheck level 2 hours after the last dose of magnesium received. And then prior to the shortage, we utilized IV magnesium sulfate for replacement. However, the drug shortage prompted our institution to substitute oral magnesium oxide within the order set, as shown on this slide. The purpose of this study was to identify the impact of an IV magnesium sulfate shortage on critically ill patients. This study was a single-center retrospective cohort study, and the pre-shortage data collection was collected in 2018, while the during-shortage data collection was collected in 2019. So within the order set, there are actually predefined exclusion criteria, such as patients receiving renal replacement therapy or those with a serum creatinine greater than 2 milligrams per deciliter, and these patients were thus previously excluded from the study based off the order set requirements. And then for the specific study population, the inclusion criteria were that patients had to be in the ICU at the time of replacement, and then the magnesium replacement had to be ordered via the order set itself. And for the specific study population exclusion criteria, patients were excluded if the order set was not followed appropriately, such as the wrong magnesium replacement regimen being selected, and then also patients who were admitted to a cardiovascular service, oncology service, or if they were admitted for a subarachnoid hemorrhage. These patients were also excluded, as these populations have their own magnesium replacement thresholds. My primary outcome was time to goal serum magnesium level, and secondary outcomes included number of doses administered to achieve goal serum magnesium level, change in serum magnesium level per dose administered, new onset seizures and/or arrhythmias, and this was defined as an event that required intervention, as well as adverse effects of magnesium oxide such as diarrhea and the incidence of C. diff testing, and ICU and hospital length of stay, and then lastly, an in-hospital mortality. Appropriate statistical tests were used to analyze differences in baseline characteristics and outcomes as listed on the slide, and statistical significance was set at p less than 0.05. So here are some of the baseline characteristics that we looked at in this study. There were no significant differences found between groups, and just to point out, that does include baseline serum magnesium level at the time of admission. On this slide, you can see some of the inpatient characteristics that we collected in this study, and the only differences noted between groups was an increase in histamine 2 receptor antagonist use and a decrease in proton pump inhibitor use in the 2018 or the IV group compared with the oral group in 2019, which this was attributed to an ongoing PPI shortage in 2018 at that time. Here you can see our primary outcome results. There was actually no difference between groups in terms of serum magnesium level that prompted the order set activation. However, there was a significant difference between groups in terms of patients who actually reached goal, with the oral group having significantly fewer patients that reached goal. And then lastly, this chart at the bottom of the slide represents the number of patients who reached goal in 24-hour increments, where each increment represents an additional magnesium replacement regimen being activated, with there being a statistically significant difference between groups within the first 24 hours, with the IV group having significantly greater number of patients who reached goal. Looking at our secondary outcomes, there was a significant difference between groups in change in serum magnesium level per dose administered, with the IV group having a higher impact per dose that was administered. And there was also a significant difference between groups in the incidence of diarrhea and C. diff testing, with the oral group having a significantly increased incidence of both. And lastly, there was a significant difference in hospital length of stay, with the IV group having a significantly longer length of stay. In conclusion, fewer patients in the oral group achieved goal serum magnesium levels than did in the IV group, and additionally, oral magnesium replacement was associated with an increased incidence of C. diff testing as well as diarrhea, while adverse outcomes remained similar between groups. Limitations of this study included that it's a single center retrospective chart review, and then also small sample size was a limitation because this study was not powered to detect a difference in clinical outcomes such as the incidence of new onset seizures and arrhythmias. And then lastly, many patients never actually made it to goal serum magnesium level, which was not something that we anticipated when we originally designed this study. For future direction, I would like to obtain a larger sample size and then gather feedback from nursing on ways to improve order set compliance. And then lastly, identify special populations that would warrant preferential allocation of IV magnesium sulfate in the event of a future shortage. Now for the self-assessment question. Utilizing oral magnesium oxide replacement in the setting of an IV magnesium sulfate shortage has an effect on critically ill patients, true or false? The answer would be true, because significantly fewer patients in the oral group reached goal while they experienced an increased incidence of diarrhea and C. diff testing. Special thank you to those who provided assistance with this project, and thank you to those who listened to this presentation.